You are watching the Doctalk Show.
You're still watching the Doctalk Show, where we are talking about the urinary bladder and conditions that affect the urinary bladder, together with Dr. Frank Asimwe, a urologist at Mlago Hospital. So we have seen the conditions that will affect the bladder and who is at risk. But now that somebody walks in with these symptoms, the symptoms you've explained to us, the infections, the blood in urine and things like that, how do you investigate and decide to diagnose them that this is the exact condition that you have?
Okay, as we mentioned earlier, the symptoms include frequency, the symptoms of infection, passing urine very frequently, a bit of pain. There may be a bit of blood in the urine. For the infection, for the cancers, there may actually be no pain, and then you may have some blood in the urine. The most basic investigation, of course, as a doctor, you must listen to the history, dig out all that, do your examination. But the most important aspect is a urine analysis. Take off a sample of urine, send it to the lab. The lab people will look at it. They will look both for organisms causing infection, products of infection like past cells, leukocytes, casts. There's a lot of information you can get from
the urinalysis.
But
that is where they give you that tube to go and
urinate in and give it to them. But the most important, at least at our stage, at our level, usually we get patients who have had recurrent infections and they have been tried on all kinds of drugs and they failed. That's where the urine culture comes in. The urine culture, they get this urine and grow it in a special way, and then they test different antibiotics on it. That's very, very important, urine culture.
Okay, that's where they decide which, now that you have been having frequent infections with a lot of several treatments, but you're still getting the infection, that they grow, like you mentioned, and then they put different drugs, antibiotics, to see what this particular infection will react to,
yes,
and then end up treating you with that, okay?
Yes. Then beyond that, other investigations include imaging, of course. We do an ultrasound. An ultrasound can tell us many things.
It is the bladder
of
itself?
The bladder. Basically of the abdomen. The good thing is when you ask for an abdominal ultrasound, they should be able to look at other organs like the kidneys, the liver. They basically try to do a good job. But on the bladder, they'll give you the anatomy, the structure of the bladder.
Okay.
If the infection or whatever is causing the problem has caused structural change or is caused by a structural change, then they will see it. Now, I'm emphasizing this because when they can do a scan and they say it's normal, it doesn't mean there is no infection. It doesn't mean there is no problem. It means the magnification of the scan cannot see what the problem is. Okay. Or me who will interpret it will say, okay, if this says normal, then it's normal. And we don't look at the conclusion, we look at the details. So that can show you if, for instance, an infection has caused thickening of the bladder wall, or if there are other abnormalities like, we call them diverticuli, they are outpouchings, pockets that pop out of the bladder
and
where
loses
urine,
its shape.
Yes, where urine stagnates, and therefore you keep getting reinfection. Of course, one of the most important things we include in the ultrasound is a residual urine volume. We want to see how much urine remains behind after you have passed it, and that can tell you a lot. And this is not normally done. We want our colleagues to begin doing it fairly routinely, even when you've not asked for it, because this can explain. Someone may not have structural changes, but they have a significant residue. If it's not captured, you will not know that there's a residue.
Okay, so the bladder is still looking okay according to ultrasound scan, but there is urine that keeps stagnating there.
That is our problem. That
you want to understand why. Oh, okay, because that also causes infection.
That causes recurrent infection.
Okay, do we have any other imaging that we do on the bladder?
Yes, we can do an X-ray. We call it a CUG, cystourethrogram. It is an imaging modality where you inject a contrast. They take an X-ray, and that contrast, with the word, contrasts the rest of the organs. So you're able to see the structures properly. Again, for outpouchings, for obstructions.
So you inject like this dye and
it's a contrast. It's actually colorless.
Colorless.
So they push it into the bladder.
Okay.
And then they ask the patient to
through the urethra?
Through the urethra, yes.
All right. And then?
Of course, other imaging modalities include the CT scan.
Okay.
The difference between an ultrasound and a CT scan is that an ultrasound has got limitations in terms of magnification. Something maybe 5 millimeters, 3 millimeters, may not see it. But a CT scan can see up to 1 millimeter.
Okay.
Then beyond that, you could do a cystoscopy. A cystoscopy means technically you look inside, and the cameras we use are magnified up to 30 times. So something which is again 1 millimeter or less than a millimeter, you can actually physically see. So there are some patients who bleed, they get bleeding, and there's a growth which is just starting, and the ultrasound doesn't see it, the CT scan doesn't see it, but when you scope, when you look
When
inside,
you put a machine and look inside,
you are able to see and deal with it.
Okay.
Of course, the advantage is that you can also pick a sample and take it for studies.
Okay.
We call it a biopsy. If there's a foreign body like a stone, you can remove it.
Okay.
And many other things you can do in a cystoscopy.
Good. So it looks like there are many things that can be done with the bladder to find out what is happening to it. So once you have made your diagnosis, how do you manage these patients?
The quick ones like infection, you have to treat with an appropriate antibiotic. Okay. If it's the first time, we have a leeway of using a broad spectrum antibiotic. But if someone has had repeated infections, you do a culture and then you treat according to the culture results. Sometimes we start with we remove the sample, it takes about 3 to 5 days to come back. While we're waiting for the results, we give a broad spectrum antibiotic. Then when the results come back, you modify your treatment
to fit what the findings show. Okay, and then we talked of these neurogenic bladders. Yes. The bladder that is not communicating, either properly. It is overstimulated and is expelling, or the bladder that the brain and the blood are not following similar instructions. The urine is not coming out. How do you manage those?
So to begin with, the investigation for that is the urodynamic test, which I said. That is a bit complex and yet simple, but basically it simulates the normal rhythm of filling, storage, and expulsion. Okay. And should be able to point to you that the problem is at filling, the problem is at storage, the problem is at expulsion, and the problem is at the bladder neck, the problem is with the muscle, the problem is with the sphincters. Okay. That's a good test to do. In the country, I think we only have one place where it's done. In Mulago, we have one machine which has taken a bit of time without working. That's not a surprise. Well, but hopefully things should get better. Okay. But we need those kinds of machines to use. Okay, it's important, of course, yes. If we are only able to do it in one country and the national referral cannot do it. Then now, depending on your findings on that urodynamics test, then you manage according to what is affected. Is it the problem of the detrusor, the muscle of the bladder? Is it the problem of the bladder neck? Is it a problem of the sphincters? Is it an overstimulation? Is it an understimulation? Sometimes you may need to go back to the neurosurgeons. You may need to do an MRI of the back. Do you have a lesion in the back? I had a child I was managing with a neurogenic bladder. She'd had a meningomyelocele. That is like a swelling of the growth. The growth and the nerves that supply the lower abdomen and the bladder. We were able to get them to India, and they did some surgery and freed some of those nerves which were trapped, and they improved significantly. The bladder issues improved. Okay. In modern medicine and at our level, at specialist level, it's very important to first zero down on what the problem is, and you deal with that problem. And our patients sometimes are a little bit anxious. They come to you, you begin treating them, you send them for an investigation, send them for a second one, send them for a third one. They're waiting for you to prescribe and give them a tablet. And like, no. I need to know what the problem is and deal with it. And then on our side, sometimes we're embarrassed to tell the patient, I am still finding out what your problem is. So the doctors need to be frank enough and say, I'm not yet sure what we're dealing with. We're still finding it out, so that when we find it, we deal with it. If the patient over-insists and maybe they have pain, you can tell them, I'm going to manage your pain, but I have not yet started managing your actual problem. Okay, because you're still trying to find out the problem. And I think that is a really important piece of information for people out there. Some of these diseases are quite complex, that when you see the doctor taking their time, sometimes they're also consulting, or sometimes they are a specialist, but they thought it was this, they investigated, and it's not that, but they still have to find out. And most of the time, the patients are just waiting for a tablet to swallow. Like here, sometimes it's not just a tablet. The cause is maybe on the back, is on the spinal cord. Maybe the cause is even in your brain, an accident you had that could have injured your brain and is having an impact on the bladder. So we have seen several ways, this urinalysis that they do, many laboratories are able to do it and find what the infection is. If you're getting recurrent infections, a urine culture ideally should be done, and then the right drug chosen for you
to be able to manage that infection. So when we get back from the break, we shall talk about cancer of the urinary bladder, and then we shall look how that can be managed and how to prevent issues that concern the urinary bladder, and also how to manage and prevent cancer of the urinary bladder.
You are watching the Doctalk Show.